So Dr. Jerry Zuckerman is the head of infectious disease for the Hackensack Meridian Network, who specializes in hospital epidemiology, infection prevention, and patient safety. I'm going to turn it over to Dr. Zuckerman for his presentation.
Hi, I guess it's good afternoon. I think maybe the size of the audience suggests that everybody's moved on beyond COVID at this point in time, but it's still with us. I guess my goal here is really to provide some updates since the last time I spoke to the group and any new information that's come out, and give you a sense of where we are once again with COVID in our communities. And I'm going to share my screen. Let's see here. Okay, you should see my screen. I lost all of you guys. There you go. All right, and Dr. Bader unfortunately wasn't able to join the call today, so you have me solo. So where do we stand? This is so. I've shown this previously. This is looking at COVID activity in our communities, how much disease is present and being transmitted among individuals. And this looks back over the last 2 months, and you can see, we had reached a nadir back in March. This was the post-Omicron surge when things had leveled out again. And then since then, we have seen an increase, a slow and steady increase throughout New Jersey and in every county in the state. And so it is still, widespread in our communities, though the severity of disease is different than what we've seen previously. We have not seen an increase in hospitalizations to the extent that we saw with Omicron or the Delta variants. And we certainly have not seen an increase number of deaths during this latest surge. So this is from the New York Times. This just shows the various graphs here. These are the new cases reported per day. The good news is we may be peaking during this latest surge. The number of daily counts has started to decrease in New Jersey. Of course, the caveat these days is that many more people are doing home antigen tests, right, and rapid tests. So, and it's unlikely, or less likely, I should say, that those individuals are getting reported to their local health departments and being captured. So even though these cases are going down, the overall number of cases may be an underestimate of what's occurring in our communities. This is hospitalizations, and this is deaths. And again, we are nowhere near the number of hospitalizations that we saw in some of the previous surges. When we had Omicron, we had over 6,000 individuals hospitalized in the state of New Jersey back in I think this was Alpha. This was back in January 2021, close to 4,000. I'm not sure we hit 1,000 during this latest surge. And again, the severity of disease was a lot less in terms of not seeing individuals in being admitted to the ICU. And this number of hospitalizations also may be skewed a little bit because, at least in Hackensack Meridian, whenever a patient gets admitted to the hospital, we test them for COVID. So some of these patients may be admitted for something and, oh, by the way, tested positive for COVID. So it may not be the precipitant for their hospital admission, but it's certainly something that we captured during our screening process. And, we've seen that more frequently as, a greater number of the population has received vaccination or previous infections. And again, the I believe the number of deaths in the US has been the lowest it's been for quite some time. So looking back, and this was from the CDC, this is looking at antibodies. So antibodies are proteins that are produced and in response to an infection. Antibodies also are the things that we produce after being vaccinated. But there are several types of antibodies for COVID-19, and this is looking at antibodies that are specifically related to whether you had an infection in the past rather than been vaccinated in the past. And you can see that younger individuals or children and adolescents, that upwards of 70% of folks in those age groups have had previous COVID-19 infection going back to March of 2020. As you get older, the prevalence of previous infections decreases. So for those younger than the age of 50, slightly older, more than 60%, probably around 50% for those 50 to 64, and then less than 40% for those who are 65 years of age or older. So, there are a couple of reasons I think we see this type of pattern here. Certainly, we know that vaccination first came out in older individuals, and those were the first groups that were eligible for vaccine, and they've been eligible for boosters. So they've had the most protection against disease from vaccination. And I think it tends to be the older the individual, perhaps the more careful they are in terms of some of the behaviors that they do, or whether they're wearing masks and what type of settings they visit. They may be more cautious than our younger adults and adolescents and children. But we do know that, and this also reflects that since disease has been so prevalent in children, we know that very few of them have died, though there have been deaths. There are much less hospitalizations. So disease is much milder in those who are young versus those who are older. So I've shown this slide before. It's just to remind me to, what the story is about COVID-19 and continues to be is about the variants that emerge, meaning that the virus, as it reproduces, as it replicates, it tends to mutate, and that there's sometimes these mutations provide an advantage to the virus so that it can be more easily transmitted between individuals, or it can evade our immune system so that if we did have antibodies from previous infection or vaccination, those antibodies wouldn't kill off the virus and it would continue to survive in our bodies. And what we see, and this is looking at the different variants and subvariants. The only thing I really want to show here, this was Omicron back around here. The reason we had these latest surges were because there were these subvariants that emerged, right? So there was something called BA2, and then there's something called BA2 12.1, and they have become more common in the community than the previous Omicron that we first saw in January, meaning that they have a selective advantage over the previous Omicron, meaning that A, they are more infectious, more contagious, and B, that they can evade any previous immunity we have had to COVID-19. So this is, what continues to drive these waves that we experience throughout the country, and especially what we experienced in the past 2 months. What's a little worrisome is maybe this is the next wave. So these are subvariants called BA5 and BA4. Again, these are all versions of the Omicron virus. These two strains are very common in South Africa, and they are seeing a surge there. And you can see that we're beginning to see these subvariants become a bit more commonly isolated. And so the question will be, will this continue to increase? And will we see, another wave of infections in individuals who are either unvaccinated or have had waning immunity to COVID-19? I think, and I don't remember last time, we've hit 1 million deaths in the US. I'm not sure if I shared that the last time we talked about this. The black here looks at deaths before vaccine was eligible. And then the lightish gray blue is deaths after vaccine was eligible. You can see that we still had a large number of people die, even though there was a vaccine that was eligible for or available for the majority of the population. And we know that vaccines do prevent serious disease and also minimize the risk of dying from the infection. So this is looking at people who are over the age of 65. And this is during the Omicron surge. You can see that the people who were unvaccinated had a much higher risk of dying than those who were vaccinated, and then those who were vaccinated plus got a booster. So there were some deaths in these groups, but they were not as extreme, not as many as if you were not vaccinated. And that's not unexpected. I mean, it's not going to prevent all deaths. The older you are, the more likely you have some other medical conditions that can be exacerbated. And so a simple viral infection can kind of put you over the edge and put you in extremis for whatever your other comorbid conditions may be. But we certainly did see a higher death rate for older individuals in the Omicron surge compared to the Delta surge. And this is for those over the age of 65. This is for 12 to 64. This may be, again, reflective of, we now know that the protection from vaccine and protection from a previous infection wanes with time. And so many people who are over the age of 65 got their vaccines way back in the early 2021. So they might have had very little protection against the viral infection at this point. And then this again just reflects the protection of the vaccine against disease. This is just against infections. And wherever you look, those who are unvaccinated have a higher case rate than those who are vaccinated or those who've gotten a booster. And the more prevalent the disease is in the community, the greater the discrepancy or the gap between these groups exists. As the disease goes down, they become closer together. But you can see here, this small, we see a small increase again, and that was really related to the latest surges that we saw with the subvariants. So what's new coming up with the vaccines? So I think the FDA Advisory Council is going to have a busy month in June. There are a couple meetings scheduled. I think one that's scheduled for this Thursday is looking at a new vaccine called Novovax. This is a vaccine that's different than the other ones that have been produced. It's most similar to kind of hepatitis B vaccine, where it just gives you a piece of the spike protein, which we develop antibodies to. So it has no live virus to it. It's different than the messenger RNAs vaccines that we are most frequently using. It's a 2-dose vaccine. when it was in a trial, it was 90% effective, but this was before the emergence of the Delta variant and the Omicron variant. So what its efficacy is against these new variants is unknown at this time. It is already approved for emergency use in many other countries in the European Union. It is recognized by the World Health Organization. So it's not a new vaccine, but it's one that has not received EUA approval in the US. And one of the factors is that the FDA has to certify the manufacturing process, and this vaccine is actually manufactured in India. There's been some delays in reaching or meeting whatever criteria the FDA has for the manufacturing process. Pfizer is up. They've submitted data for vaccination for children less than 5 years of age. So currently, Pfizer is the only vaccine that's available for children who are 5 years of age or older. They are seeking approval for those children between 6 months and 5 years of age. It's a 3-shot series, at least during Omicron, it was about 80% effective, but there was a very small number of cases, and so they continue to monitor this group, and longer-term data will hopefully come out over the next month or two. And then Moderna is also seeking EUA approval for various groups. They are currently for adults only, but they're seeking emergency use authorization for the adolescents and for children. And they are also seeking approval for vaccination for those who are 5 years or younger. And unlike the Pfizer vaccine, this is a 2-dose series. Preliminary data suggests slightly less efficacy against infection, and it's lower in the older age group between 2 and 5 versus less than 2. It's not clear whether this less efficacy is related to the fact that it's only a 2-dose series versus a 3-dose series, but that's stuff that the FDA will assess during their advisory meeting. So these are things that over the next 2 weeks, you'll probably hear more about whether they get approved or not. And once they get approved for emergency use authorization, the CDC will then come out and recommend who to give it to and what groups should be eligible for those vaccines. So where do we stand with current recommendations for vaccination? This is the recommendations for individuals who are not immunocompromised, who do not have any thing wrong with their immune system, meaning that they don't have cancer, they're not a transplant patient, they're not on medicines that suppress the immune system. And so in the current state, the Pfizer and is the only vaccine, again, that's eligible to be administered to those children between 5 and 11. The primary series is 2 doses, and then it's recommended, and it's really recommended for all groups that they should get a booster shot, regardless of the age. So for children in 5 months after the 2nd dose, and a 3rd dose, which is the booster shot, would be recommended. For the older groups, age 12 and older for Pfizer, and for ages 18 and older for Moderna. Again, the 2-dose series, the booster dose, the 3rd shot is recommended at least 5 months after the completion of that 2-dose series. And now for those individuals who are over the age of 50, it's recommended that they receive a 4th dose. So this would be a 2nd booster that is administered at least 4 months after your previous booster. And then with the Janssen vaccine, they also recommend 2 boosters. I will say that the J&J vaccine really should not be used. I mean, only in really select circumstances where someone cannot tolerate, for whatever reason, or had a severe reaction to allergic anaphylactic reaction to the messenger RNA vaccine. But it clearly is inferior to the messenger RNA vaccines. And so it's not one that I would recommend receiving, nor does the CDC recommend it as as the preferred vaccine to administer. For individuals who are moderately to severely immunocompromised, it's the same principles here, except remember, if you're not immunocompromised, your primary series consists of 2 doses. If you are severely or moderately immunocompromised, then your primary series is actually 3 doses, because it's been found that you need to get 3 doses to get you antibody levels up to a level which would provide protection. And then they would be eligible for booster doses and then a second booster dose. So anyone who is severely or moderately immunocompromised would also be candidates for the second COVID booster dose. So, the question, should you get a booster? I think, the first booster, absolutely. The current definition of being up to date with COVID vaccinations is completion of the primary series plus a booster. So, there's no question in my mind that if you haven't had a booster, then you probably are, you are susceptible to some of these subvariants that are circulating around. And then the second booster is recommended for those who are over the age of 50 and people who are moderately or severely immunocompromised. The other question again is, what other measures should I take? Should I continue to wear a mask? And I think these are where we have to do our individual risk assessments. Am I someone who's going to be susceptible to having complications because I'm getting chemotherapy for cancer? Am I someone who has a high risk of being exposed to someone with COVID-19? And what's the disease that's in the community? What's the type of virus that's circulating? How likely am I to have some protection? And, where am I going, right? If I'm going outdoors, then, that's a different situation than if I'm going to a crowded rock concert or to a Broadway theater, where you're tightly packed. So, we really need to assess our individual situations and risk. But clearly, in addition to vaccination, the most effective measure the second most effective measure to prevent getting COVID-19 is by using respiratory protection. There's been some recent studies about long COVID, and this came from the CDC, looking at individuals who've had complications after COVID infection, meaning they've had conditions that continued greater than 20 weeks after their infection. For individuals who are over the age of, between the ages of 18 and 64, about 20% of those individuals have developed or developed some long-term related condition, and those over the age of 65, about 25% of those individuals developed long-term complications, and they vary, right? So they could be related to blood clots because we do know that people with COVID tend to have a higher risk for developing blood clots. So this may be a risk that continues after the COVID infection resolves. They may continue to have respiratory problems, shortness of breath, asthma, neurologic and mental health conditions such as, the brain fog and depression and fatigue. So all these things, it's may occur. If you look at long COVID, people tend to have maybe two long-term conditions, but not all these occur in everyone. And, the other question is, if I get vaccinated and I get a breakthrough infection, can I get long COVID? And it looks like the answer is yes. So this was a study from the VA looking at breakthrough infections. And so if I was vaccinated and had a breakthrough infection, compared to someone who was unvaccinated and had an infection, then the individual who was vaccinated and had the breakthrough infection had a lower incidence of any long-term COVID or long-term complications. However, compared to uninfected individuals, individuals who had breakthrough infections did have a higher risk of death and complications at 6 months after the infection. So, meaning that long COVID can occur in individuals who are vaccinated. It's less than if you were unvaccinated, but it's more than if you never got the infection in the first place. And then this is just looking at a study that looked at various aspects of long COVID, increased risk in women and those with high history of anxiety disorders. Again, a lot of neurologic issues such as fatigue and concentration impairment, the brain fog, memory impairment, and then some respiratory complications such as shortness of breath. Interestingly, there's really nothing objective that you can find on physical exam, and most blood tests and stuff are normal. And they have not really, we really don't understand what's causing the long COVID. There hasn't been any evidence that the virus persists in our body or that we developed an autoimmune response to the infection where we start attacking our own body. Or have some type of abnormal immune activation. So there's a lot to be learned about long COVID, and hopefully more information will come out so that we get a better understanding. But clearly the best way to prevent long COVID is to prevent getting infected with COVID in the first place. Just to remind everyone to get a booster. And I think that was the brief update that I had to share. And I give the screen back to you, I think.
Thank you, Dr. Zuckerman. That was very helpful. We appreciate this opportunity to hear these updates from you every month. This is one of our last webinars. We have one more on June 21st at 6 p.m. So I encourage everyone, if you have questions, please jump in and ask them. Our opportunities to ask Dr. Zuckerman and Dr. Reeder are limited. So please jump in, please utilize the chat or unmute yourselves. This is quite an opportunity to ask your questions and get an answer at this level of expertise. So, okay, so Cora has a question. Some of our participants are worried about the boosters having more side effects. Any thoughts?
Yeah, thanks for that question. So there's been no evidence that there's increased side effects after the booster shots compared to previous ones. So, and there's no correlation. Like if I had a reaction after the second shot, there's no correlation that I'll get a reaction after the third shot or after the fourth shot. So they still tend to be minor. I mean, you know, you can have some low-grade fever, you can have muscle aches, joint aches, all, you know, taken care of with mostly Motrin or Tylenol. But there's nothing that's really been significant that's really popped out as being worrisome in getting a first or second booster.
Okay. Caitlin asks, what was the effectiveness of the vaccine for children ages 6 months to 5 years old?
Yeah, so that depends on the vaccine right now. The Pfizer vaccine was slightly more effective during their trial. It was 80% effective, as opposed to the Moderna, which was around, I believe, 40 to 50% effective. And you know, these trials were during Omicron, so it's kind of with the latest versions of the virus, which is good. And that's against getting infected at all. Children, tend to have a very low risk of having severe complications or dying from the infection. Of course, if it's the one child that dies from it, it's obviously a very devastating event. But that's the current efficacy of the vaccine, at least in these studies. And, a lot of the data is very limited right now because most of it is released in press releases from the company and not really published at this point. That we begin, hopefully next week, we'll be able to see what was submitted to the FDA. So we'll have a better sense of what's the data that they're presenting to the FDA in terms of efficacy and side effects.
Stephanie asks, do you recommend a fourth shot / booster for pregnant women?
Yeah. So, it's a good question, important question. I think, with pregnancy, there are really two things that we need to consider. We need to consider the mom, and we need to consider the unborn child. And so for a mom, we do know that COVID can be more severe in pregnant individuals. And knowing that vaccination can wane with time, or immunity can wane with time, it's not unreasonable to get a fourth shot in that group. And knowing that these antibodies will cross the placenta, they would also provide some protection to the newborn child. I don't know, and I'll have to go back and check whether pregnancy is one of the groups that they are currently recommending for the second booster. So I would have to confirm that, and I can get back to you about that from Melanie.
Okay. Sandy asks, what are the differences between the two PO, I'm not sure what that stands for, PO antiviral meds approved for COVID treatment?
Yeah, we haven't talked much about antiviral meds. So there are two that are approved, Paxlovid and Molnupiravir. The Paxlovid is the one that is more effective against preventing progression of COVID to severe disease, to requiring hospitalization. So these medications are really indicated for individuals who have mild disease and are at risk for going on to develop severe disease. So again, someone who's older, someone who has comorbidities such as cancer or end-stage lung disease or emphysema. Those groups would be the ones who we should be administering antivirals to if they develop an infection as an outpatient. The Paxlovid is preferred. One of the concerns with Paxlovid is that it can interact with other medications more frequently. So it is important that either your primary physician or the pharmacist really review the medication list to make sure there's not any significant drug-drug interactions. There are some medications that you can just stop, right? So if you take a medicine to lower your cholesterol, you can stop that for 5 days and not really experience any harm. But if you're taking a medicine because you have a kidney transplant, then you're not necessarily able to stop that medication. So that's where you need to balance the risk and benefits of the medication. Unfortunately, Paxlovid is not prescribed as frequently as it should. I think, in the medical community, it's still a lack of information has percolated out there, and maybe undue or excessive concern about the potential drug-drug interactions. But you can give the medicine safely. It does, prevent going on to develop severe complications. And so if I was at risk for a complication or developing severe disease, and I developed COVID, I would have no qualms about taking the medication.
Okay. Caitlin asks, with the low risk and low mortality rates with COVID in children, how do we talk to parents about getting children vaccinated?
Yeah, that's a great question. There's still so many unknowns, with this. So, a couple of things. Even though the risk is low, if it is your child that happens to die or happens to develop a complication, it's an N of 1. It's 100%, right? I mean, even with flu vaccine, we recommend flu vaccine to children over the age of 6 months, but we know it's older people who have more complications and die from influenza. But if you ever, if you have a child that dies in the community from influenza, it's all over the news, right? We always hear about the children dying from influenza. So, it's just, that risk is there even if it's low. Children tend to be in environments where the virus can more commonly circulate, right? I mean, children tend to share things with each other, and masking is much less consistent. Some young children can't even, can't tolerate a mask. So I think, the likelihood, and as I showed before, 80% or I think it was around 70% of children had already gotten COVID, right, in the past. And having COVID in the past doesn't mean that you're not going to get it again, because you can get it again. And then the third thing, I think, is you have to look at your individual family situation, right? So if you have a child and you have an elderly grandparent, 85, 90 years old in the house that you want to try to put as much protection around that individual, and not allow an opportunity for COVID to come into the house. That would mean, vaccinating everyone in that household to try to minimize the risk of disease. So there are many different things that are, that you can talk about. The reality is that I think a minority of parents right now are interested in vaccinating their young children against COVID. There's very little, I don't know, and I don't think we do know what the long-term sequelae will be if a child gets COVID. Will they have long-term COVID? Will it affect their development? I don't know. But, so there's still a lot of unknowns. And, as long as the vaccine is safe, and there's no untoward side effects and significant reactions, I think it would be, in my opinion, better to offer, some additional protection compared to what we don't know about what may occur if you get COVID-19.
Okay. Haley asks, what are the signs of myocarditis in children, and how long after they have had COVID can they show symptoms?
So myocarditis is inflammation of the heart muscle. And it could be, someone can get chest pain, it could be pain. If the heart muscle gets swollen, doesn't function well, they can get short of breath. It's kind of like if you exercise and you lift a lot of weights and you never did that before, and then your muscles get really, they hurt, right? That's probably some inflammation there. The same thing can occur related to the virus and our immune response to the virus in the heart. It is most likely transient, so it can last, for a short period of time. People recover fully from it and do not have any long-term heart complications, and are able to return to their activities. It may take a month, it may take 2 months, but it's certainly unlikely to persist for prolonged periods of time. And certainly athletes have been able to, return to their sports unimpeded after having myocarditis with COVID. It's not a frequent complication of COVID, but it can occur.
And how long after they have had COVID can they show symptoms of this?
Usually it's, within the first, couple of weeks after the infection. I think it would be extremely unlikely, 6 months later, to develop signs and symptoms of myocarditis.
Okay. Dr. Zuckerman, everybody says thank you in the chat for your answers. I have a few follow-up questions to your presentation, but please jump in, everybody, if you continue to have questions. In one of the later slides, you had talked about women and those with a history of anxiety disorders being at increased risk for long COVID. Are there any thoughts about why this might be?
Yeah, no, it's just an observation, really, looking at, a group of people who've developed long COVID versus people who haven't. And, and that just occurred more frequently. The etiology, the cause for long COVID really is not understood at this point. So, if maybe there's some genetic component to it that affects women more than men. But those are things that we really hopefully will learn over time. And, it's one small study. And, depending on the groups that you look at, different populations may, pop out in different studies. It's really hard because there's no set definition for long COVID. And exactly what it is and how you define it and how you diagnose it. So it's something that we will be learning about for the next couple of years to come.
How do you feel about all of these unknowns? Is this just the normal course of things? Is this something
Yeah, no,
specific
I
to
mean,
COVID?
we've been living with it for 2.5 years. And the virus is new. It changes. Each time it changes, it's kind of like a new curveball, and we're learning from it
Mhm.
as we go along. Um, but I do think, the one constant, I can't emphasize this enough, is I still think there is great value in um, minimizing your risk of getting COVID and minimizing the severity of COVID if you do happen to get it. That is one thing that we've learned that is constant, that vaccines are protective, will make it milder disease, masking will protect you. Um, so I think a lot of the unknowns are, where we're going now is what are the long-term complications, and
Mhm.
if you happen to get it. I think the other things we have to learn about is how frequently can we get COVID if we get it, right? So will this be, will we get infected every once, twice a year, every 3 years? How often will we need a booster shot? Will it be annually like we get with the flu vaccine? Some of this depends upon the virus and how it kind of evolves with time. And some of it depends on how well our immune systems adapt to the virus and able to keep it in check as new things come up and emerge.
Okay. Um, in one of your earlier slides, maybe it was right in the middle, you had that chart with all of the dots that shows the dosing. For the age category of 5 to 11, there was the 2 initial doses followed by a booster shot at 5 months, but then it ended there. Do you foresee a 4th dose for that age group?
Yeah, so currently they recommend one booster dose for everyone, right, who's a candidate for vaccination. The second booster dose is only for those groups that are at higher risk for complications. So the elderly and the immunocompromised. As we've talked about, children are less at risk for those complications, and that they're may not get as much benefit from a second dose as an older individual. So, you don't want to give everyone everything, right? You want to weigh the risk and balance, risk and benefits of it. And when it comes to the second dose, it's probably clearly more beneficial for someone who's 90 versus someone who's 9.
Okay. And does that have to do with supply?
No, it
Okay.
just has to do with that, the likelihood of developing complications is a factor of age,
Okay.
right? So we have plenty of vaccine. That's
Yeah.
no longer an issue.
Okay. We've been hearing from families that those with cancer or an autoimmune disease, that their doctors are recommending they don't get vaccinated. And you had talked about this in your presentation a little bit. So I just want to make sure I'm understanding. So it's not that the vaccine is a danger to them, it's just that they might need an additional dosage of it?
Well, I think people who have cancer and other autoimmune diseases are the exact group who should be getting vaccinated and boosted, and get a second booster. That's the group that I would be most worried about for getting complications from COVID, and that we have a tool to help minimize that risk, and that would be vaccination. So those are the folks that I would strongly encourage to get vaccinated.
Thank you, as always, for guiding us through all of this and being with us here today.
If it helps bring the message to the community and, about the importance of vaccines and stuff, then I'm happy to do it.